All right, thank you everyone for joining us today and welcome. My name is Matt Flory and I am the Health Systems Manager for the American Cancer Society's Midwest Division. Recently I've been working with the National Colorectal Cancer Roundtable to identify health plan best practices for covering colorectal cancer screening. And I want to thank everybody for joining. We've had a lot of interest in this topic and appreciate your time. People are still joining the call, but we just wanted to get moving quickly. Today's webinar is the first in a series of mini webinars that will profile best practices around 80% by 2018 in different categories. Health insurance plans play a key role in achieving increased colorectal cancer screening, but many of us have questions about what specific health insurance plan practices actually lead to increased screening. During today's webinar, Dr. Andrew Zinkel, Associate Medical Director of Quality at Health Partners, an early supporter of the 80% by 2018 effort, is going to share some of Health Partners' experience with colorectal cancer screening efforts, including work they have done to use data to address disparities issues. We'll also highlight an NCCRT 80% by 2018 resource document and what insurers can do to advance 80% by 2018. I've had the good fortune to get to know Dr. Zinkel and Health Partners thanks to my position in the Midwest Division, but I want to point out that their story is just one of many that we're starting to hear around the country. Whether on a small or large scale, health plans of varying scopes and sizes can make positive changes to increase screening and reduce disparities for their member populations, and to support coalition efforts in the markets in which they're present. A few quick housekeeping items before we get started. We are recording today's webinar. The replay and speaker slides will be shared with all of you within a few days. And because of the large number of participants, all participants will be muted. We do encourage you to ask questions, though, by submitting them through the webinar Q&A function. We will have time for questions after the presentations, and we'll answer as many as we can. We will also be emailing around responses to any questions we don't have time to get to. You can also always email us specific questions after the call. We are asking for your help in evaluating the webinar, and you will be receiving an email with a survey link, so please help us out with feedback. We hope you'll join us for our next webinar on the 80% by 2018 Exemplary Program Services, which is scheduled for Tuesday, October 20th from 12:30 to 1:30 Eastern Standard Time. And we'll focus on what primary care can do to achieve 80% by 2018. So again, the purpose of today's webinar to examine best practices that health plans can undertake to advance colorectal cancer screening, to hear from an expert in the field about what it's like to implement these practices, and to learn about existing and coming resources. We do have time for Q&A again through that official panel. I, at this point, would like to turn the presentation to Dr. Zinkel and ask him to keep us moving along, if that's all right.
Thank you, Matt. Can you hear me?
Yes.
All right.
You should have control of the slides as well.
Okay. So again, my name is Andrew Zinkel. I'm an emergency physician by training. I still practice 40% of the time in a level 1 trauma center here in the Twin Cities. And then the rest of my time is spent as the medical director for quality for the health plan, overseeing our HEDIS metrics, our STARS ratings, all these things. So I can speak to that and to colorectal cancer screening today. Just a little bit about Health Partners, where I work. We are a non-for-profit, consumer-governed, integrated system. So we have both a health plan and we have a delivery system. We have about 22,500 employees. On our health plan, we have 1.4 million medical and dental members in Minnesota and surrounding states. In our clinics, we have about 1 million patients, 1,700 physicians, 3 different medical groups that have joined. 55 medical and surgical specialties, 48 primary care clinics, and we are multi-payer. We have 60 dentists and 22 locations of dental clinics and 7 hospitals. And one point is that we only care for about 40% of our health plan members within our delivery system, and the rest is done through our network contracted partners. So what are the issues? So there's disparate practice guidelines out there. Messaging is done to members about screening recommendations and benefits from various different locations and sometimes have different messaging. Clinician engagement can be an issue. Clarification of billing and claims practices from the health plan side can sometimes be an issue. And then consistent administration of the insurance benefits for members. So what are some health plan specific strategies for members? So communications, again, these can come from different sources. They're statewide communications, some come directly from the plan, some are in partnership with public entities, and then some are coming from their own primary care doctors. Intelligent reminders, one thing we utilize is microsegmentation data, which I can talk about in more detail. We focus on racial, economic, and geographic disparities, and we make sure that our reminder strategies are culturally specific and aware of the culture that we're speaking to. And then we try to make the prep easier to obtain and understand for colonoscopy in particular. This is an example of some communications that you would see on a billboard in Minnesota. They tried to use a bit of humor at the Department of Health, and it's definitely eye-catching. Some health plan specific strategies that we utilize for clinicians is trying to standardize our billing and coding, making sure they understand that they're actually billing and coding it correctly, and in particular, preventative versus diagnostic billing codes can be an issue. Making sure that there's quality incentives out there for clinicians to incentivize them to do this more often. Incentives to just gather information. Sometimes that's the first step, is understanding who in your practice has not been screened and needs to be. To help them with that, we provide registries to clinics of patients that have not been screened and are due. We recognize high performance publicly. We have performance in excellence awards that we hand out to clinic groups that are performing highly. We locally have ICSI, which is available nationally. It's the Institute for Clinical Systems Improvement, and it's a regional body that helps to create up-to-date guidelines about messaging and things like that. And then we try to make the issue broader. It's not just colon cancer, it's your complete health. This is an example of the most recent ICSI guideline. And we follow ICSI guidelines when we do our screening. We do not follow always HEDIS, because HEDIS is slow to take up the new guidelines when they're put forth by governing bodies. And so ICSI typically will be a bit faster, and so we sometimes will take a hit on our rates if they're not up to date on the way they're being measured. So the aims are to increase the rates of patients who are actually up to date, and then also to increase shared decision making over colorectal screening tests and what's out there. Some health plan specific strategies. We use the elimination of benefit administration confusion. So this statement here, if you fall asleep with zero copay, you should wake up with zero copay, was an issue for some of our members in the past when a colonoscopy would be performed as preventive, but then if the physician doing the procedure removed a polyp or did some type of thing that was more diagnostic, they would then bill as diagnostic and the patient would get hit with a copay. We fixed that problem so that the patient will not get a copay even if they bill incorrectly. Colonoscopy following a positive fit should be covered as long as it's billed preventive. Again, the major issue here is making sure that providers are educated and that they know to bill it as preventive. If that's the case with our insurance company, it will go through as covered under the ACA at 100%. If they bill it as diagnostic, it doesn't always happen that way, and so it's an issue of educating the providers. We try to sponsor transparency initiatives so that it's clear how we do this process. We leverage our relationships with clinicians both inside our network and inside our delivery system. And then the ability to have tested change within our care system, since we're an integrated delivery system, is helpful as well. So this is the HEDIS colorectal cancer screening rates from 2009 to 2014, and our 2015 rates have been pretty much identical from 2014. So, you know, we had a hard time increasing our rates. They're great rates at this point, close to 70% initially, and didn't really change much until last year, and we had a nice bump last year up to around 75%. And so we're trying to get to that 80%, but you know, if you look at this, the amount of change you get in a year is small, and so we don't have a lot of time if we want to get to 80% by 2018. Statewide, this is Minnesota in particular. Our rates have been slowly again creeping up from 64% in 2011 up to 68 in 2012, 69 in 2013, and up to 70 now in 2014. I don't have 2015 data or an estimate on that at this point. But again, you know, the rates are going up, but they're going up slower than we'd like to see it. And this is from Minnesota Community Measurement, which is a nonprofit body here that promotes the publication of quality metrics for the public. This was from the 2013 data, just an example of how it's actually split apart by clinic. And one thing to note here that's unique, and I'd appreciate feedback from anyone on the call if they've seen this as well, is if you look at the top 10 clinics on this chart, 6 of them are OB-GYN clinics. And so, we've looked at our data for overall preventive care screening, and we've seen that, at least in our region, OB-GYN clinics pretty much hit the top mark more often than anyone else, and I'm not sure why that is. We are looking into that data, but it's a unique thing that we've noticed in our region. This shows some of the major health systems, at least in our region as well. And the point being, so Health Partners and Park Nicollet combined, and we are one now. But if you look at colorectal cancer screening, it's clear that this is a priority to all of our large clinic groups. We're all performing highly, and we're all making it a priority. We're not saying, okay, we're performing high enough at this point, let's concentrate on other things. It's consistently a priority for every large primary care group. So how do we make it easier? Make the screening easier for the members. Having multiple options, so the FIT or the fecal occult blood tests are available by mail. We mail them out to our members, and they can return them to their clinic to have it tested. And then obviously there's flexible sigmoidoscopy and colonoscopy. We partner between our health plan and our care delivery to try and increase our rates, as well as with our network providers. Effectively coordinating our outreach. Our organizational structure supports accountability. So internally in our delivery group, we publicly show the rates by provider and compare them to their peers, so that gives them a little push to work towards higher rates. And then broader than colorectal cancer screening. So picturing all of your health and the other effects that colorectal cancer could have on your life, making sure they're considering their entire health is important. So health scores is one place where you can look to if you're looking on, how do I find out where I can get a colonoscopy? One of the things you can do is go to this website and search by name, city, or county, or by zip code. Find a provider where you can actually get colorectal cancer screening done that's close to you. It's a handy tool. This is something we did is our colonoscopy to-go box. It's sold at our clinic pharmacies. It includes the prep materials, information for the procedure, a little humor, do not disturb seriously, door hanger, some little games to pass the time, and it won a graphic design award, but we thought maybe adding a little humor would be helpful. What are the benefits to a health plan? So ultimately the benefit is the healthier members. You want to decrease disease, pain, and suffering. You want to lower a leading cause of cancer deaths. The benefit to the health plan also is you get better HEDIS and CMS star scores, which are public information and important. And then ultimately, also lowering healthcare costs within the idea of the AAA. So what are some barriers? Billings and claim systems are complicated. It's hard to get the process reliable at times, and it takes work. Hard for some plans to be a local plan. So for some of the larger insurers that have a national footprint, it's more difficult to get things done in certain regions because you have less connection with that region. Processes vary across payers, which in turn leads to confusion for clinicians. So they're not always certain what's covered at what rate. There's competing priorities. The uninsured represent an issue we all share. And then it's sometimes hard to connect members who are not attributed. So when we're trying to create our registries for people that have not been screened and are due for it, if they're unattributed and don't have a primary care provider that they're connected with, it's hard to reach out to them with our messaging. So overall, health plan strategies in support of the goal, you need to prioritize and make sure it's always a priority year after year. Strategize the ways you're going to work with the community and with the provider groups. Collaborate with them, help to facilitate the process, educate them on how billing and claims works, standardize the process, and then recognize and reward them. With that, I will turn it over to Mary.
Yeah, thank you. That was wonderful. So just real quick, I know I see a lot of questions coming in for Dr. Zenkel, but I did want folks to be aware of a few resources that we have coming out soon that hopefully will be helpful to folks on the phone. And then I also, much like Matt, I did want to acknowledge the work of many other health plans that are playing leadership roles in this area because this is a mini webinar series. We are featuring just one health plan, but you know, we know there's wonderful work going on by Kaiser Permanente of California, Geisinger, Independence Blue Cross Blue Shield of Philadelphia, and many others. So, you know, hats off to all of you. We've had over 26 health plans sign the 80 by 18 pledge and really want to acknowledge the work of all of those partners. So just real quick about a few resources that I want everyone to be aware of. One, hopefully most folks have seen this, but the Roundtable did produce a series of backgrounders that I sort of thought of, so you've signed the pledge, now what? What can you do now that you've signed the 80 by 18 pledge? And we have 5 existing backgrounders now geared towards different audiences, one on what health plans can do, one on what employers can do, one on primary care practices, one on community organizations, and one on hospitals. So in just a moment, I'll show you where to find those on the Roundtable website. We also have a new issue brief that's coming out soon. I hope to be able to send it out to everyone who's been on this call, which just in a couple weeks, on how to make the case for waiving cost sharing for follow-up colonoscopies when you're working with health plans. And then finally, longer-term plans. We did receive CDC funding to develop a health plan best practices manual, and we're extremely excited about that. We hope to be able to show, put the spotlight on a whole bunch of different good practices that are going on that plans are doing to help both give those plans credit, but most importantly to serve as a learning tool for others who want to engage in this work. So the tool I mentioned about what to do now that you signed the pledge, if you go to nccrt.org/tools, you'll see a number of different resources, and at the very bottom is what insurers can do to advance the 80 by 18 effort. So if this is just a snapshot of what the cover of that backgrounder looks like, and I'm not going to go over this in detail, but it has 6 different steps that health plans can take, much of which mirrored the presentation by Dr. Zenkel, different ideas that health plans can do about how to advance screening rates. And, you know, a lot of it Dr. Zenkel touched on, but some, you know, in a nutshell, the 6 things that we thought of were, you know, setting the system-wide goal at 80%, using data in strategic ways. I think Health Partners has been so creative in how they've used data to educate providers, to educate patients, and to close disparities. And then also, as he mentioned, educating clinicians, health plan staff, and patients about coverage. And I love the idea of sending around a few examples of what Health Partners has done so that you can look at that more specifically, promoting quality screening options, incentivizing providers, and then being familiar with the barriers to screening from the patient perspective. The Roundtable did take a very close look at the unscreened audience and how we can best communicate with them. So in follow-up, I can also send some resources in that area to help empower plans to speak to the unscreened in a way that we know works. So this is a screenshot of my teaser for the fact sheet that we're doing on the importance of waiving cost sharing for follow-up colonoscopies. You know, essentially, there's, you know, I think as many of you know, different protections afforded to patients around cost sharing being waived for colorectal cancer screening, but it's not completely clear, according to the Affordable Care Act, whether or not if a person goes in for an FIT test and that test comes back positive, you know, is that follow-up test covered? We would love to be able to work with plans. Gateway Health Plan in Pennsylvania has just announced that they're waiving cost sharing for those follow-up colonoscopies, and we think there is actually, you know, some very good reasons for doing so from the plan perspective, and we share that. We hope to be able to share more detailed thoughts on that soon. So with that, I know we have an awful lot of questions coming in, so thank you to all of you for joining to learn more about this important topic. And Matt, I'll turn it over back to you to field questions.
So I think now, Mary, if you and I could, maybe we could take turns keying up the questions, some of which have come in through the deck. And I wanted to start, Dr. Zinkel, with a question about billing in particular. Can you talk a little bit about what Health Partners has done or is planning to do to educate providers about appropriate use of billing codes or other best practices to increase colon screening?
Yeah, so we've done more general education, both to the network providers and internally, on what's the appropriate way to bill for this. And this really came up with the issue when people were going in for what they were under the impression was a preventive screening test and covered, and then the provider would take a polyp off or do some kind of part to the procedure that they considered diagnostic and would bill it as diagnostic even though it was a preventive screening test going in. And so it was more of an education that those are still considered preventive screening. And the issue, I think, was more making sure that they understood that. It took us going through the appeal process to realize this was happening, and we had to fix it. So we definitely had some issues initially, and so we've fixed it in that way.
Thanks. And I'll take the next question. We did get a question about at one of the colorectal cancer roundtables, it was mentioned that even if a provider coded as preventative, a facility may charge for diagnostic if polyps were removed. So I'm so glad that question was asked because it's confusing, and the reason it's confusing is because the law is different whether you're talking about a private plan or whether you're talking about a Medicare plan. So the way the Affordable Care Act was worded, unfortunately, within the Medicare population, it's very, CMS has maintained that if a patient goes in for a colorectal cancer screening, there's no cost sharing or deductible. But if a polyp is discovered, the deductible is still waived, but then the copayment applies. CMS has also said that that has to be fixed legislatively. So ACS Can and others, Fight Colorectal Cancer, the GI organizations have been working very hard to pass some legislation that would fix that. Now, on the other hand, among private insurance plans, the Affordable Care Act is quite clear that the cost sharing is waived, as Dr. Zenkel mentioned. If a patient goes in for a colonoscopy screening and comes out with a polyp removal, then no cost sharing applies in that instance. And then forgive me for yet one more exception, unless it was a grandfathered plan, and we can send out some more information about that as well. So Matt or Dr. Zenkel, I know people always get tripped up on that, but please do comment on that explanation.
Yeah, and I'll just add that the grandfather plan is an issue, and so we have to send out 3 different types of letters when we're saying you need to follow up for your colonoscopy. 2 of them are not grandfathered plans, but it's basically commercial Medicare, and then the grandfathered plans have to have different wording because they're not all covered at 100%. There is the cost sharing with Medicare.
Great.
Dr. Zenkel, we have a question about the health scores data, and it says, did the clinic level screening rates that were shown reflect all covered members or only the members served by your group? Can you help explain some of the work that Health Partners and other health insurance plans in Minnesota have done really to create some market consistency with ICSI and community measurement, and just kind of clarify whose data that is or how the health plans have worked together to support that kind of market approach?
Sure. So that data was specifically from Minnesota Community Measurement, which is, again, a public website that posts quality metrics for clinics in Minnesota. That was a consortium that was created with both the health plans and the provider groups working together and trying to have more accountability and visibility into the quality work that our clinics are doing, and also to try and raise the bar. And so it is, I believe it's a sampling of charts from the clinic that they use to ask for a chart audit from the clinics, and then they post that data online. So it's not the entire population. I believe it is a chart audit.
Well, I will only correct you, Dr. Zenkel. There will be very few times where I'll ever actually know something more than you, but I have the unique ability to only pull at the colorectal cancer data because I'm looking there. So it is confusing because community measurement does both. And at least you did start that way as a sample, but if you pull the paper reports, most are doing a direct data pull from directly from their electronic medical records, so the N's are very large. So it's complemented with chart audit, but if people go to Health Scores, and we can make the website available after this, they will see that in the most recent rounds of data, we have over 700 clinics actually reporting, and they're pulling it directly out of their EMR. That's something that's possible in Minnesota because you know, over 90% of our provider groups are on EMR and have a high meaningful use ratio. So it is more than chart audit. It's actually a direct data pull. That's not necessarily the case for breast cancer screening or some of the other measures, which are either chart audit or just aggregate HEDIS data. This is direct data for our colorectal measure.
That's helpful. Thanks, Matt. So we do have another question coming in for, now we're calling you Dr. Z. Have you had any challenges mailing FIT kits to patients of contracted providers? Do you have to get their consent first?
I don't believe we've had to get their consent. If they're a member of our health plan, it's important that they get screened, and I think we can promote that in any way we'd like to. Have we gotten feedback from other provider groups? Yes, we have. Most of the time it's positive, but not always, and so I don't believe we need their consent to do that. I think we just send them out to the people that have not been screened if they want one. They have options, obviously. We're not saying everyone should get the FIT test, so it's if they want one.
Mm-hmm. Excellent.
Dr. Zinkel, I have a question for you based on, you know, disparities. Can you talk a little bit about what Health Partners has done to approach different populations where the screening rate is lower, whether that's the Medicaid population or, say, the African American population? Have you done, you know, not just covered the whole, you know, made sure everybody gets a mailing, but have you done any work to tailor messages, you know, and what results have you had from that?
So yes, we have done some work. Obviously, there's age differences in when you should be screened for different populations, and so we again adjust our letters that we send out to the appropriate age group and have a separate letter for you know, populations that have a lower age at which they should start being screened. So we did change our letters in order to make sure we adjust to that. We have seen I would say a significant increase, particularly in our African American population, where when we started measuring, we had a gap between patients who are white and patients of color of about 26% in 2009. And the latest data I have is from 2014, and that gap is now only 8%. So we have seen an improvement based on the change we made with our letters to improve screening rates. We've done other things on a geographic basis where we've targeted particular clinics where we've seen lower rates and tried to reach out to them as well.
And so just to be clear, the African American population, what age do you start mailing them at?
At 45, well, 44, I guess, to say they should get it next year.
Okay.
That's an excellent question, Matt. Thank you, and thank you for that wonderful response. So we got a question for you, Dr. Zinkel, more for Health Partners as an employer. So does your health plan provide pay time off to employees for them so they don't have to use their vacation time in order to have the colonoscopy? This is an incentive we are considering for our employees to get screened, and I do have a comment on that after you respond.
So we do not currently. I love that idea, and I might have to suggest it.
And just to follow up, we have learned that in, I believe it's New York State, and I'll try to confirm this for folks with follow-up afterwards, that they are testing that for state employees and doing an evaluation of that. So I'm hopeful that with after that is implemented, we'll have some data to share with folks about how paid time off works and you know, if it does result in an increase in colorectal cancer screening rates. So another question again about this confusion about coding. The question says, our providers have said that they must document a scope following a positive FIT test as diagnostic. They said it was illegal to document it incorrectly. Is it a potential issue to bill as follow-up scope as screening?
So I am not a biller or coder, but I have not heard that before. That may be coming from the provider group. That may be coming from, I don't know if there's differences in state laws on that, but I have not heard that. I don't know if anyone else can speak to that.
So you know, this is an issue the Roundtable has been looking at, and we can try to provide more guidance. Certainly there's always the fear that if you code something incorrectly, you can get in trouble for it. But my understanding is that it's a matter of combining different codes with the initial code so that you can still indicate that something is being done as screening even if it is coded as a follow-up fit test. I've seen different ways that that's done, and we do work with some wonderful billing experts. Joe Brill from AGA and T.R. Levin from Kaiser Permanente has had some advice on this. So we'll try to pull some more detailed guidance and send that around to folks, as I know this is an area of great confusion.
Dr. Zinkel, just another question, more of an open-ended one, either because, not necessarily because you might have a strong recommendation, but just kind of a gut sense. Is there an area of opportunity that you think you know, health insurance plans might be able to figure out if they were engaged or in partnership with other kinds of stakeholders, something that maybe, not that's going poorly, but that could be accomplished more successfully if health plans were able to partner with other stakeholders to get increased screening?
Well, I guess my response to that would be, you know, internally, we've partnered very closely with our informatics department, and I would recommend doing this if you have the capabilities. I mentioned briefly microsegmentation data earlier. We've gotten enough data on our members from various resources that we can, you know, predict who will or will not likely schedule their colonoscopy or screening test in the next year. And then we've gotten enough data on those particular people that we know how that population responds to different types of marketing. And so we've actually tailored the style of marketing and the actual messaging based on that data to attempt to increase our rates. And I don't have data yet from colon cancer, but we did a pilot study in breast cancer screening, and our rates increased by about 20% by doing that. So we're hoping we'll see the same with colorectal cancer screening.
Great, and so many good questions coming in. I'm learning a lot from this webinar myself. Again, for you, Dr. Zinkel, what kind of incentives were put together for the colon cancer screening to providers?
To providers, in particular, it was a financial incentive, and I don't know the exact financial incentive they use, but I know that they do get a financial incentive if they hit a certain mark or rate within their own clinic.
Okay. And then this may be the last question, unless we have a few others come in. Do you know if there are plans to add colorectal cancer screening as a HEDIS measure for Medicaid?
I do not know the answer to that.
And I actually do have a comment on that. The Roundtable has been doing a 50-state assessment of Medicaid programs to try to understand different interventions that Medicaid programs are doing around colorectal cancer screening. And while you will not be surprised to learn, we found that in many instances this is just not on state Medicaid programs' radar for the very good reason that they have historically served women and children and are only now in expansion states beginning to serve those who are in the over 50 population to a much greater degree. So while we found that there was a lot of states where it wasn't quite on the radar yet, we also did find examples of some good news where there was some innovation going on in this area. And I do believe that as a part of that report, we are going to be highlighting as a recommendation a possible addition as a HEDIS measure of Medicaid. So, Laura, you're a step ahead of us. We are just now thinking about that, but I myself think it's a great idea and something perhaps we can pursue.
Mary, and this is Matt, at the risk of crowing a little bit about Minnesota, but also underscoring the importance of that, we have been tracking, our Medicaid program has been reporting that as a state-level metric, and Community Measurement actually has a report that tracks by aggregate the screening rate both at the Medicaid population and the commercial population. And it does show a pretty significant gap. It's been 20% 4 years in a row. So it actually shows that the Medicaid screening rate is going up and the commercial screening rate is going up, but the gap seems to be pretty persistent. And just by a quirk of math, it seems to be exactly 20% for 4 years in a row. And you saw that a little bit of that just from the health partners data that they had that MSHO, which is the senior health option. That's a dual eligible population. So that was internal data from health partners, but we do have aggregate data for the state Medicaid program, and you can find that report on the community measurement website. It's the health disparity report, and we can make sure that people can find that if they're curious. But the gap has been 20% consistently for 4 years in Minnesota, in spite of the fact that we report it and are working on it.
Wow.
I think health partners has maybe had a little bit better success than others in closing it.
Wonderful. And then just a follow-up question, when is the report that I just mentioned going to be available? We hope to have that available in a couple months. The plan is to release it around the time of the Roundtable annual meeting this November, so I'm hoping folks won't have too long to wait. And I did speak too soon about the last question. We did get another question in. Does anyone have a process for following up on fit cards given out but not returned? And I can also send around a manual that the Roundtable produced specifically for community health centers on how to put practices in place to ensure good screening processes. And and that question is addressed very specifically in there. The manual, of course, by its title, was designed for community health centers, but I would say 85% of it is about process improvement and good screening practices, and it will be useful to to many folks out there, not just community health centers. Matt or Dr. Zenkel, comments from your perspective about putting processes in place to track returns?
I would just say that I think our clinics at least use the registries that we give them, and so if they know that we've sent a fit card out to a member and they don't have a scheduled appointment in the next 6 months or so, I think the clinics have someone that reaches out and tries to call them by phone and set up an appointment and make sure they bring it in and all those things.
Okay, great.
I think what I would add, Mary, is at least in Minnesota, the provider materials that the National Colorectal Cancer Roundtable has put together, everything from the full provider toolkit down to the simple one-pagers explaining, the physician's guidance on FOBT and FIT have been very well received. And I think the more that we can develop simple materials to help people understand how to put together a really effective stool-based program, the better. That said, Dr. Zenkel, could you comment briefly on, what Health Partners has done to encourage their members to maybe think about tests besides colonoscopy? You sort of touched on it, but have you actually put the option question out there in general, or do you generally follow up with people if they don't seem to have gotten colonoscopies, or maybe a little both?
I think we follow up with them if they haven't been tested in the period that they need to be tested. And so we send out letters and we say, here's your different options. You can do a FIT test. You don't have to do a full colonoscopy at this point. And so I think we try to educate them that it's not just colonoscopy. There are other options. And we do that for everyone, no matter what test they had previously.
Great, and there's just so much enthusiasm for this topic. We are still getting questions coming in, so forgive me for falsely suggesting we were about to end, because we still have several more. This question: is there an ACS summary document that we can use with providers that explains the importance of billing colonoscopies as preventive and the confusion with out-of-pocket costs with Medicare? So I'm pretty sure we have some stuff available on cancer.org/colonmd. There's also a document that AGA put out that really gets into the weeds, explaining all the nuances around coding and when cost sharing might apply to patients. I completely agree that we need to do as much education about this as possible, because it's an area that we continue to get questions on.
Dr. Zenkel, are there any tools that you could share about what you've, what kind of instruction you've given to providers about billing? I guess that's share any tools or communications you've developed to educate providers about the need to code correctly.
Yeah, I mean, what we do is we have something called FastFacts, which is it's a newsletter that goes out to all the providers within our network, and that's the main way we communicate to providers external to our own clinics. And so that's where we've tried to put the information on this and gotten some positive feedback on it. I should clarify one thing. I believe our fit tests are only sent to our own clinics, not to outside contracted provider clinics. So.
Great. And then similar question to what Matt just asked, what is best practices for your health plan in educating providers, and what's been the most effective with colon cancer screening education around everything from guidelines to coding to billing, et cetera? Dr. Zinkel?
I'm sorry, can you repeat that again? I missed the last half.
Sure. No, it's similar to what Matt just asked, but what would you consider best practices in terms of communicating with providers about everything from screening to coding to billing?
You know, I think just making sure you're putting that education out there. You know, you can't guarantee they're always going to read an email newsletter or something like that. So making sure that we're educating the public as well. And then I think we get education out there through recognition for groups that are performing well and giving out awards. But you know, I think just educating it again and again it helps to get through.
Yeah, and you touched on something good there. Can you talk a little bit, whether it's in colon screening or more broader, what kinds of things Health Partners has done to provide recognition to high-performing or highly or most improved providers, and how you've seen that sort of impact primary care practice or colorectal screening?
Sure. I mentioned previously we have something called Performance or Partners in Excellence Awards that we hand out every year, and we highlight different quality metrics, but colorectal cancer screening is one of them. We did create a new award this year, or actually 2 years ago now, called the Preventive Screening Award, and it's for groups that perform highly in various areas of preventive care screening. The other ways that, of course, they get recognition are through the data that's in Minnesota Community Measurement, which is public, and can show that their clinic is the top performer there.
I do want to add, Dr. Zinkel, I really appreciate both your support and the support of other Health Partners staff in our coalition efforts, not just to have a state roundtable, but your organization has been very active in our provider education work group and helped us promote provider education webinars to get tools like the NCCR tools or content and information out about shared decision making. So thank you for supporting those community efforts at provider education as well.
Another interesting question. What efforts are happening to get insurance companies to honor colorectal cancer screening for ages younger than 50 for certain populations? So I'm assuming this means for those who are at high risk either because of a family history or a genetic condition. You know, is colorectal cancer screening being covered for those individuals?
If it would be a preventive screening, I guess, to me, I think it would be billed the same as a preventive screening, but I don't know for certain. Yeah,
you know, this is one of those areas where if the Affordable Care Act ties to U.S. Preventive Services Task Force, the task force does say that for those with a family history of colorectal cancer screening, screening should be covered, though they may have a different frequency. So, you know, I think for the most part there is that's something that should be covered. But of course, as always, if you're hearing about examples where it's not being covered, we'd love to learn more to try to help.
What I will say, Mary, in the sake of the Minnesota market, we do have the good fortune of not only having companies like Health Partners, but other payers that do have these conversations and do have open door relationships with other stakeholders. So I'm not saying it doesn't happen, but I'm not sure that we have the same level of concern. And you know, I think that's in part because the health plans and the other stakeholders have supported guideline organizations like ICSI and measurement groups like Community Measurement. So there really is sort of strong agreement. And, you know, I don't know, Dr. Zinkel, if you could comment on just how Health Partners has conversations with other insurance companies in the market around whether it's colon screening or just issues in general. I know there's some limits to what you can talk about in terms of coverage with each other because of you know, regulatory questions.
Sure. I mean, we have the Minnesota Council of Health Plans, which meets, I think, every other month, where leaders from all the health plans get together. But I don't think they're able to talk specifics about billing. It's probably an antitrust issue.
Right, right. But I mean, you do have, we have at least had good conversations with health plans. We tend, as other stakeholders, as questions come up, to try to bring them back to health insurance plans like Health Partners, and Dr. Zinkel has always been, open to at least answering a question or looking into a question if we brought them in the past. So I think my suggestion to folks is one of the clearest ways to make sure people honor it is just to have conversation with them or to connect people that have questions, to the health insurance plans if they can.
And the person did actually send a follow-up question that she was asking, not in terms of high risk, but for people of color. I believe ACG, and forgive me if I'm getting that wrong, is one of the guidelines-making bodies that suggests that African Americans should start screening at 45. U.S. Preventive Task Force, ACS, and others suggest 50. So, I imagine this is getting a bit into which guidelines different plans follow.
But I think Dr. Zinkel commented before that they actually they not only cover it at 45 for African Americans, they send mailings.
Wonderful.
Is that right, Dr. Zinkel?
For African Americans and for Native Americans, yes.
Great. And then could this be a false one, but the new last question is a great one. From the health plan perspective, what do you think we, as ACS staff and roundtable members interested in supporting colorectal cancer screening rates, what can we do that's most helpful to support plan efforts?
I think I would say to that is to have a good relationship with them. Stay involved, co-sponsor things in the community, and just having that relationship where we can talk to each other and help each other out with things that are important to the community. I think that's the best way to do it.
Okay, great. Well, thanks very much, everyone. Just a really wonderful turnout today, and a special thank you to Matt for your wonderful facilitation skills, but especially Dr. Zinkel for such a rich presentation, so much good food for thought for all of us in this space. And, of course, thank you to the CDC who provided funding to make this webinar happen. We do have another series of webinars coming up. Please mark your calendars. The next will be later this month, September 29th, on evaluating systems changed focused on colorectal cancer screening. Please note that it is a new date and time. We had originally scheduled it for the 20th, but it moved it because of a conflict. And then another one on the 20th on the second in this mini webinar series on exemplary practices from primary care's perspective, and then an upcoming one in December about a new publication about New York City's C5 coalition. And for more information, please don't hesitate to email me if you have any follow-up questions. But again, really appreciate the wonderful turnout. And again, Dr. Zinkel and Matt, excellent job today. Really appreciate your time.
Thank you.
Thank you, everyone.